My guest today is Dr. Kenneth Aigen, Associate Professor and Director of Music Therapy and Vice Chair for Faculty Affairs at New York University. Hello and welcome, and thank you so much for joining us today for this conversation.
I'm very happy to have the opportunity to talk about music therapy to people who are interested in it.
So, Dr. Aigen, what is actually a music therapy?
What is music therapy? That's a question I've been asked and have answered for the last 42 years, ever since I found out about it. So a couple of things. I'll limit my answer to the US because while there's a wide spectrum of practices in this country, I don't want to assume that anything I say is true for the world in general. So music therapy is quite a small profession, maybe 10,000 board certified music therapists in the country. But for such a small profession, the spectrum of practice is incredibly broad, all the way from working with pregnant mothers in musically assisted childbirth to working in palliative and hospice care and bereavement. So we can see from before birth to after death, music therapists work. And then the spectrum of who music therapists work with is incredibly broad as well, from some people who might do stress reduction in a corporate environment to other people who work with individuals who might be in very minimal awareness states, even comatose and things like that. I'm just saying that as a preference, as a preparation to give the sense that whatever I can say in a few minutes about music therapy can only really skim the surface of an enormously broad area of application. Similarly, for a small profession, there's a wide spectrum of methods or approaches. Some are much more at the scientific medical end, and others are much more at the creative and improvisational and psychotherapeutic end of the spectrum. So you have music therapists who perhaps work purely on physiological goals and parameters, and then others who work on relationships, emotions, psychological development, so that you see music therapists whose work is medical in nature, that is more rehabilitative, like working, well, on the medical end, you might have people working in pain reduction using music so that people would need less pain medication. That would be a typical medical application. Then you, in the middle of the spectrum, things that are more rehabilitative, like if someone's had a brain injury or stroke and is recovering motor function or speech, music therapists works on what we call the rehabilitative level. Then there's an area of what we call didactic music therapy or psychoeducational music therapy, where music therapists might work in schools with students to help them develop cognitive constructs through music. And then at the other end of the spectrum, you have the psychotherapeutic area of practice, where any sort of internal emotional or relationship goal that you could imagine someone working on in psychotherapy, you have music therapists who are trained to work in there. I will say in the US, music therapists have to be experienced, skilled musicians. So it's not the case that a music therapist is a social worker or a psychologist or psychiatrist that brings music recordings in. Music therapists in the US have to have minimum competencies on voice, guitar, piano, and percussion instruments. The idea is you want to be able to provide the music that's needed for a wide range of clients. The other thing is music therapy generally is not primarily music for people, it's music with people. So to the greatest extent possible, music therapists bring their clients into active music making. Now you say, well, how can they do that? Not everyone's a musician. Well, first, a lot of music therapists work with their clients through singing. Many people enjoy singing that aren't trained or skilled musicians. But also in music therapy, we use a lot of high quality instruments that are very expressively rewarding, but that don't require a lot of skill and training to play. For example, we would tend not to use, say, a trumpet or a violin, which could take years just to make a pleasing tone. But we might use a piano, or we might use drums, cymbals, gongs, chimes, things that don't have a steep learning curve. Or we have special xylophones and marimbas that are perhaps tuned to a pentatonic scale, so that people can walk right up to it and just sit and play and make something that sounds pleasing. So to the greatest extent possible, music therapy in this country is music with people, not for them.
Dr. Aigen, would you call music therapy a medical discipline?
I think I would rather call it a health discipline, because there are certain aspects of the medical model that don't suit all music therapy practice. Now, some music therapists, for example, there's a model called neurological music therapy that might agree that they do as a medical practice. However, there are many of us who work at the other end of the spectrum who say, you know, there are many things about a medical paradigm that don't really capture human relationship to music. So that it's not the case, you know, in medicine, you have an authority figure who determines what will happen to the patient. In music therapy, we like to think of it as more collaborative. We like to meet people, find out what their affinity for music is, and work as a partnership. Also, medicine is not an apt metaphor for music, because if you think about, I know there are exceptions, but most human bodies will react very similarly to a medication, to penicillin or something, for example. But music isn't like that. The way that people engage with a particular piece of music, for example, is so much mediated by personal history, experience, preference, values, culture, or how they're feeling that day, that we can't really, I think it's an inapt metaphor to say that music is like medicine, because it's not something that there's a universal reaction to in the way that medication, for example, or surgical procedure is.
Yeah. So you mentioned already some uses of the music therapy, like in the prenatal care and in the palliative care. But I also, when I was reading about it, it said that music therapy is also applied in correctional facilities, work with children who have attention deficit disorders or mental development or emotional development disorders, which is actually one of your specialty. I also read a very interesting data that ICU patients have 65% more success of recovering if the music therapy is applied there. Is that true?
Well, you know, there are, I don't have the statistics or figures at my fingertips, but certainly there are Cochrane reviews and meta-analyses looking at music and music therapy in different environments. Again, the issue is that because it's a small profession, the distinctions we make aren't all accepted in the outside world. So a nurse playing a music recording in an ICU might be considered to be doing music therapy by some people. We would say that's more like music medicine, because music therapy, beside, you know, it's sort of circular reason to say only a music therapist can do music therapy. But, you know, there are things such as individualizing the treatment, basing one's musical intervention on assessment and development of individualized goals that makes it music therapy. So, for example, someone doing a study of music in the ICU might just say, okay, we're going to play 30 minutes of Mozart a day and see how it affects people's respiration or heart rate, and see if it affects it positively. While that would be music medicine, it wouldn't be music therapy, because there's no effort to
create individual. I understand. So this is very interesting, because how do you, so music therapy is actually something you need to prepare in advance. You have to look all the elements. You have to put all this together. So how do you actually, how one musical therapy looks like? How long do you need to prepare music therapy? What elements you're looking into before you even start a musical therapy?
Yeah. So I would say for students just beginning out and young professionals, it's very helpful to have a session plan. And much like a teacher has a lesson plan that day, beginning therapists and students come in with a set of activities they may do. More experienced therapists can come into a situation, take the emotional climate, of a group, for example, and draw from the group what would be meaningful and meet their clinical needs this day. One day it might be we're going to write a song together. Another day it might be we're going to listen to music receptively and engage in guided imagery and music. One day it might be we're going to do a group percussion improvisation. It really depends upon where the clients are that day, what the particular needs are. So again, experienced therapists can, but still it's individualized because there's an effort to find out where the group is today or the individual and what the person's needs are on that particular day. So I would say the planning varies. It varies according to the experience of the practitioner, but it also varies according to the theoretical perspective. So there are music therapists who work from a very behavioral framework. And so those therapists would tend to come in with more of an active plan for what they're going to do today on a given day. And whereas those who are more psychotherapeutic in nature are more willing to just come into the moment and do the kind of moment by moment planning and assessment based upon what's happening with the client that day.
So you said that only music therapists can do a music therapy session. So does that mean that, let's say, some psychologists or psychiatrists, do they have to have a training, or they can just go with the flow? Or
well, I think music therapists, my mentor was a man named Dr. Clive Roberts. We don't own music as music therapists. So of course, many psychotherapists or psychiatrists might want to bring music, a recording of a pop song into a session and engage in something called lyric discussion. That's something that music therapists would do, but I also think there's probably nothing wrong with a counselor or psychologist doing that. However, people who are not trained music therapists may not understand the extent to which music can release and trigger things in people and what it accesses deep within them and what to then do with the feelings that are released and stimulated by the music. So when I said only a music therapist can do music therapy, that's our preference as music therapists, although, most states don't have a legal definition of music therapy so that only a music therapist can do it. Although we're trying as a profession to carve that out. Someone could incorporate music therapy into a psychotherapy work, but that doesn't mean they're doing music therapy. That's kind of what I was getting at. Music therapists, there's something called the Certification Board for Music Therapists. Music therapists take an exam to get board certified so that on a national level in the US, there's a recognition that only people who've graduated from certain academic programs are even eligible to get board certified as
I was actually going to ask you, sorry for interrupting, but music therapists actually goes to school, right? They go 5 years to become music therapists. So can you tell us a little bit about the process? So let's say I decide to become a music therapist, what would I have to go through?
Sure. So it varies a little bit. Again, to become a music therapist in the US, generally, the only way is to go to a university program in music therapy. It's approved by the American Music Therapy Association. And those programs have a practical experience requirement of 1,200 hours of supervised clinical work with a music therapist. So there's an academic part, and there's also a practical part. will say there's been a strong effort currently in the US. People with an undergraduate degree in music therapy can take this board certification exam and become a professional music therapist. There's a strong effort in the country to make the master's degree the entry-level degree for music therapists. If you look at dance therapy, art therapy, drama therapy, they all require a master's degree for the level. And music therapy is sort of an outlier in that way. But, if you look at music therapy degree programs, for example, at NYU, we have a 60-credit master's degree. All 60 credits are in music therapy. So we have courses in children's methods in music therapy, adult methods in music therapy. We have 2 courses in improvisation. We have a course in voice, how to use the voice in music therapy, course in music therapy research. We also have something unique, a music therapy group, which are experiential training groups in which students, it's like a quasi-therapy experience led by adjunct faculty members, where students come in and are clients in a music therapy group for 2 reasons. The primary reason is we all come with our own inner fears and blocks. Some of us may not be comfortable around expressions of anger or expressions of sadness or depression, or we may work well with cancer patients, but we had a sibling who had an eating disorder. So whenever we encounter a client with an eating disorder, it might bring up feeling. Or we might be very comfortable and great pianists, but when it comes time to sing, we get quiet and we are very inhibited with our voice. So the idea is that in this music therapy group course, which is a quasi-therapy group experience, students learn to work on themselves. They realize that who they are as human beings determines the parameters of what they can do as music therapists. And so the idea is to promote their growth and development, much in the way that happens in the practice of psychotherapy. If you go to a psychotherapy institute, most trained therapists have to be in therapy themselves to become more fully self-actualized.
Can music therapy replace classic therapy?
Replace what? I'm sorry?
Can music therapy replace the classic therapy sessions?
Classic, yeah. Well, that's a really good question. I mean, I think when music therapy was first being created in the 1940s and 50s in this country, I think people felt, well, this is really good for people who are either nonverbal, maybe they're autistic children, or they're withdrawn or shy or so traumatized that they can't talk about it. So initially, music therapy was seen as good for people who can't engage in verbal psychotherapy. I think now that the profession has been in this country for 75 years or more, and it's matured, people see it as it offers possibilities even for high-functioning adults like you and me who are seeking a therapy. But, there are many people who've sat and talked about their problems and conflicts for years, and nothing. And so an action therapy like music therapy helps someone to more outwardly embody their feelings. And so I would say it wouldn't replace traditional psychotherapy, but it offers an alternative for certain people that might, in many cases, be more effective than a purely verbal psychotherapy alone. Music therapists at advanced levels are trained in verbal methods and how to integrate their use of music experiences with verbal interactions.
Verbal interaction, I understand. So your specialties include working with children and adults with emotional and developmental delays and adults in mental health. Can you tell us how one clinical section looks like? I know that you're in academia right now, but can you clue us into what happens when the client walks in the door?
So let me tell you a little bit about a specific method, which doesn't represent all methods, but it's the method that I was trained in. It's called Nordoff-Robbins music therapy. It was created by a partnership between a concert pianist composer, Paul Nordoff, and a special education teacher, Clive Robbins. The essence of this approach is something called clinical improvisation. And the idea is that the therapist learns to create a musical context around whatever a client naturally does, so that the sounds and movements that a client engages in gradually acquire communicative significance. So let me give you an example. Let's say working with a nonverbal autistic child, okay? Children like that rock and rhythmically. I don't know if you've ever seen one. They just might go
yes.
They make nonverbal sounds, ah. They might do that. So they walk into the room. There's instruments around the room. Therapist is at the piano and sees this rocking. Here's the tonality of the vocalization. Starts improvising in the rhythm of the rocking and with the tonal center of the client's vocalization. Starts treating it as if it were music, as if it is singing. So then the client's tones might alter to reflect the harmonies chosen by the therapist at the piano. Or the rhythms might change, or the therapist may sing back, and it becomes sort of an improvised dialogue. And so what happens in Northrop-Robbins music therapy, what initially might be habitual and without intentional communicative intent, gradually becomes an example of joint music making. And once you have this realization that there's a partnership here, the child might have for the first time a recognition that what's going on out there is related to something in here. And so you can't teach someone
connects with the world.
You can't no. doesn't even have a concept of communication. But once you provide someone with an experience of communicating with another human intelligence, now you can develop relationship. You can start introducing singing and words and verbalization. Same thing if the child walks in and just sees a drum and starts just hitting it, which a lot of children will do. They'll see a drumstick and a drum and they'll pick it up and start playing. We, again, will work with the tempo and the phrasing. We'll introduce melodic rhythms or little rhythmic melodic statements. See if the child reacts rhythmically. Now you have communication happening in the music. And then you say, well, how does the therapist know what to play? The idea is you look at the person's facial expression, their body motion, you try to feel into them, and you create music, harmony, scales, styles that reflect your sense of the inner person. And so it's not just the behaviors and the observable things that you're reflecting, you're also trying to create music that you think will speak to this person because it reflects their inner being. And in this Northrop-Robbins method, you can say, well, that's very creative and improvisational, which it is. It takes very skilled musicians who then understand disability.
And a lot of preparation. What
we do is, sessions, in the old days, they were audio recorded. Now we video record everything. The therapists watch the videotape after the session prior to the next week's session, and then say, okay, when I was playing this Dorian mode, I can see the client's eyes lit up, and she seemed really engaged by that particular tonal relationship. There was something in that. Or that little melody, the motif I introduced, I saw her turn her head. So I'll bring that back next week. So what we do is we'll notate motifs and themes and melodies that seem to
work.
And we'll bring this back the following week so that gradually in the Northrop-Robbins work, although you start out improvisationally, you soon build up a repertoire of themes and motifs and songs that become sort of the skeletal structure of the session with given clients. So now, remember I was telling you about the spectrum of music therapy approaches?
Yes.
This was only at the creative or improvisational artistic end. Because we're working improvisationally, we're not planning ahead of time. The idea is that we want to react to what the client does in the moment. So if you want someone to relate to you, you have to relate to them. Coming in with a list of activities ahead of time isn't relating to them. Like you and I are having a spontaneous conversation here. It was kind of why, I'm sorry about that.
Okay.
Um, we're trying to encourage relating and relationship in autistic children. So that means we have to relate to them as full human beings, and we try to relate to them through the music as fully as possible.
I was wondering, so is music therapy beneficial to children without emotional and developmental delays? And how, and what way? And if so, does music therapy exist in schools here in US? And what are the standard procedures in applying music therapy in school?
Yeah, I think there's very little music therapy in most public schools.
Mm.
That reason is most, and I worked in the New York City Department of Education at the beginning of my career, but I had to go get it, even though the principal wanted music therapy, I had to go get a teaching license because their mission is not therapy.
I know that. Yeah.
Right?
Mm.
Because their psychotherapy doesn't suit their mission, it's
Mm.
hard for music therapists to get in public schools. What happens more often is private schools that aren't limited in that way will tend to hire music therapists, especially for children with multiple disabilities or autism or emotional challenges, because they find that traditional talking therapy really isn't the recommended treatment for children. And part of the power of music therapy, and I think this is true especially for children, but for everyone really, is that the person doesn't feel like he or she is in therapy. They just see it as music time. And so if you think about a pediatric hospital, a child's waiting for surgery. Everyone who comes in is doing something painful to that child. A painful procedure, inserting a needle, giving a shot. They're in lab coats. Adults in a psychiatric hospital. Everyone's an authority figure telling them what to do. Music therapist walks in, not in a lab coat, but perhaps in everyday clothing, holding a guitar and a laptop to do some hip hop on GarageBand or drum. And a completely different expectation is established. Whereas children with emotional challenges or psychiatric patients may have a visceral resistance or reaction against someone in a position of authority, sometimes for good reason. Music therapist walks in and says, well, yes, I'm a therapist, you're a client, but on a more fundamental level, we're two human beings who are going to meet together in music. And I think music therapy clients of all ages and of all needs feel that. And it's sort of that dissolving of a hierarchical relationship that is what makes it so effective.
So I see some beautiful guitars behind you. So let's say you are that man, you are that guy who walks into the hospital room with a child who is waiting for the surgery, and you have your guitar, and you have all this knowledge and experience that you do, and all these books behind you that you do that we're going to touch up later in a conversation. What is the first song you do? What is the first thing you do after high?
The first thing you do is, would you like to hear some music? Would you like to play some music? No, I'm too tired. Okay, well, sometimes when we're really tired, it could be soothing. Are you having trouble sleeping? Yeah, I can't sleep. You know what? I'm going to play some soft music for you. And if it helps you go to sleep, that's fine. Or if it wakes you up and then you decide you want to try one of my instruments, we'll do that. What's your favorite music? Well, I like the music from, I was reading about it today, Walt Disney, Little Mermaid. Oh, I know that song. Would you like to hear the song that Ariel sings? Yeah, that's one of my favorites. Okay, we'll do that. So basically, you try to access the person's preferences.
I understand.
You don't have any predetermined idea about what the music will be used for. It could be used to help a person, express their fears. Hey, would you like to write a song today? No, I'm so scared. I have my surgery tomorrow. Oh, well, sometimes it helps if we write about the things that we're afraid of. Yeah, let's do that. And I'll say, well, what do you, so you sit down, or the person might want to completely escape the reality of the surgery is tomorrow. And it's like, I wish I was home. I wish I was in the woods behind my house. Oh, yeah, I like going out in the woods too. Maybe we'll write something about how it feels to be out in the woods. So the idea is you draw from the person how that person will use the music on that day. You don't come in with any predetermination.
Predetermined. Mm-hmm.
That's what makes it psychotherapy. So that's where you're doing the individualized assessment.
Mm-hmm.
Letting the person, personally, I like to talk to my students and I say, listen, music is a universal health resource. And it's something that we all use that endows our life with meaning. And if we truly believe that music is a universal health resource, then there's a human right to music, just like there's a human right to food and shelter and clean air and clean water. There's a human right to music. And as music therapists, we're just the vehicle for helping that client access their universal human right to music in whatever way will best advance their health or well-being in that moment.
Are there risks in doing music therapy?
Yeah, I think in doing, people have looked into that a little bit. Is music therapy ever contraindicated? That's the next term, right?
Yeah.
I think the risks are when it's used without a sense of how deeply it can touch certain people, how music can access repressed memories. Sometimes traumatic memories are repressed for good reason, because the person doesn't have the resources to consciously deal with them and cope with them. And music often can bypass areas of defense. Now, if someone is defended against human relationship, like some autistic children perhaps, it's actually good that music can bypass the defense and reach someone's desire for human contact. But when it's used to bypass a defense that's highly functional and needed, then that's an example of where it can be destructive and dangerous. So you say, how do you know? Because we sensitively engage with the person, feel them out, get a sense, do not push, do not make an agenda about what we're going to do today. Because like I said, that child in that hospital bed, if you can read the symbol, if you can listen to the words and listen to the emotion behind the words, you'll know what's safe and what isn't with this person.
So recently, a very sad event happened in Belgrade, Serbia, where I actually come from. There was a school shooting, and one 13-year-old boy killed 9 students and wounded another 9 students. And there was also a security guard who was killed. And it was really sad, and the whole nation is just really upset. It was about 3 weeks ago, so we're still in mourning. Do you think that music therapy is something that could help these kids who witnessed that, who saw their classmates being killed? In what way? And is it now time for it, or maybe a little later? Do you have any experiences? How would that work in US? What would be the standard procedure for that? How are the children helped?
Yeah, there's something in our area, in our profession called community music therapy, where people tend with larger groups of people when a community has encountered something that's traumatizing. And so music therapists do go in and have gone in, and unfortunately, there's been a lot of need for that in this country. We won't go into that now.
Yeah.
Personally, I think, of course, this is probably one of the most difficult, challenging, traumatic experiences a human being could have. Witness violence against their friends, family, loved ones in any way. So if I was a music therapist coming and I was asked to come into that situation, I'd first say, well, I'm not going to come in once and do something and then leave. If you want to plan a sustained course of treatment for as long as the people who need it, let's do that, because then we can take our time, we can ease our way in, and we can help people through the various stages that they may go through. I would also say, I'm not going to come in and work with 15 or 20 or 30 people. Let's do some small group work. Let's bring people, children, at the most 7 to 8 at a time in small groups. And let's go in, but let's just see how people are doing and not introduce the idea that I'm here to help you with your feelings of what you just witnessed, right? You can address someone's psychological and mental health and well-being without necessarily identifying, I'm here to address that. So if it was me, I might come in, just check in. Hey, I'm Ken. I'm a music therapist. That means I come in and make music with people. It helps them with whatever they're feeling at a given time or day. And I have some instruments here, and maybe we'll play those today, but let me just see how everyone's doing today. So in a way, you take the time to read the emotional climate, and then you determine, maybe we'll do a group songwriting experience. Maybe we'll just do percussion improvisation so that people could play and release pent-up feelings without having to label it, without having to say, this is how I feel about my friend getting shot. They don't have to identify or label it. The idea is that sometimes you can release tension and anxiety directly through the music or sadness, and it's still therapeutic whether or not you put a label on it, right? And sometimes, in terms of trauma, the theory of how to treat people with trauma has in recent years has changed. People used to think, well, we need to get people talking about what happened so that they go through. More current theory says that could just be re-traumatizing. That could just bring it back and make people relive it. And so the last thing you want to do is have people talk about it. So the idea is that
you want them functioning first, I guess, right?
It just depends. Some people really will want to or need to talk about it. With kids, boy, that's with children, their resources are so much different. And they tend to work things through on a more symbolic level to begin with, rather than on a concrete level. Again, it depends on the age. A 5-year-old and a 12-year-old, so different. But I think the idea is not to walk in with any agenda, to plan sustained contact, to have the option of, if someone's particularly disturbed, to have the option to see people in individual therapy. And so you come in with a plan and contingencies, and an idea to determine if and when music therapy could be used in this setting.
I have 2 questions. So first question is, how long do you think after such a big trauma, music therapy can start seeing the way with the children? That's the number 1 question. And number 2 is, are words important? How are they important in music therapy?
Yeah. Again, I hate to claim any knowledge that I don't have. I'm not specialized in work with trauma.
Right.
So I don't know what the current thinking is. Do you want someone to come in as soon as possible? Do you want a few days or a week or 2? I do know that the need can be for months or longer, so that once you start, it can't be, sort of just a blitz, quick therapy, and then we're out of here. You have to be ready to be in there for the long haul.
Longer time.
Yeah. So that's what I would say. Anything should be sustained. How important are words? This is something of which, there's some debate. I'll tell you my opinion, and I'll also say that it might a minority opinion in the field. I think, music therapists who work in a therapy way would often say, well, you have to put words on the experience, otherwise it's not therapy, it's just music. I don't necessarily agree with that. I think sometimes people can have transformative experiences that occur solely and completely through the music. So, for example, I have a lot of colleagues who work in psychiatry, and very often they'll work improvisationally with a group of adults, anywhere from 4 to 8 people in a prison forensic setting or just a psychiatric hospital.
Mm-hmm.
And often they'll engage in group improvisation using percussion instruments and things. And sometimes people have really powerful and moving experiences that way. I mean, as a musician, you know that we develop certain powerful feelings with the people with whom we make music.
Oh, yeah. Mm-hmm.
Right? So now, someone who's in a prison or psychiatric, someone who's been schizophrenic since they were 18, has no job, has no family, has no work, vocation, nothing that makes them feel fully human, all of a sudden can have these beautifully wonderful, communicative, expressive experiences with other people through music. And sometimes music therapists will reflexively say when the music's over, hey, how did that feel, everybody? What did that mean? What did you do? And I'm not of that school. I'm of the school of sometimes forcing someone to talk about it can diminish its importance and meaning, because then you're limited to putting a word on something that's a wordless experience. And so it can, be untherapeutic to force it into a verbal box. Now, there's also the opposite situation. I have colleagues who work in a method called analytical music therapy, where a lot of the idea is to release unconscious feelings through music and then become conscious of what was released by reflecting on it and putting words and interpreting the music. What was the meaning of that? So what I will say is, I articulate a position that said, sometimes we do want to analyze the music. Sometimes the music can be self-contained and it requires no verbal analysis. And in fact, the verbalization might be counter-therapeutic. But then there's also a middle ground where we can talk about the music without necessarily analyzing or interpreting it. And so someone might just say, wow, I never thought I could do that. It felt wonderful. I never thought I could play music with other people, or I felt these feelings of joy come up, and I haven't felt joyful about anything in years, So someone might talk about the experience, or I loved when we were communicating and I played the pattern and you answered back, and I played the small thing and then the group responded. So people can talk about the music without necessarily analyzing or interpreting it, just describing how it felt after. So, full spectrum, not talking at all to talking and analyzing, and any of them can be therapeutic in my view.
So you're past president of American Music Therapy Association. Can you tell us a little bit about that? And can you tell us what actually American Music Therapy Association does right now?
Sure. So again, a little bit of history, and if you remind me at the end, I'll send you an article I co-wrote with a colleague of mine on this.
Please do. Mm-hmm.
So the first music therapy association in the country was formed in 1950, called the National Association for Music Therapy. In 1970, another association was formed because people had some different ideas about how music therapy should be practiced, or primarily different ideas about how music therapists should be educated and trained. And so there were now, from 1970 to the early 90s, there were 2 different music therapy associations, which was very counterproductive. Because anytime you're trying to achieve something in the society to advance the profession, you have to first explain, well, there's 2 associations, and this association offers this credential, and this one offers that credential, and they're similar in this way and different in that way. Legislators don't want to hear that. They would say, come back when you get your own house in order. So then in 1998, the 2 associations overcame their differences and unified.
Hmm.
So it was the National Association for Music Therapy and the American Association, NAMT.
Yes.
In 1998, they became the American Music Therapy Association, AMTA. And that's the organization that exists today, 25 years later. The mission statement is really simple. It's to provide enhanced access to quality music therapy services. So everything the association does comes down to that. So what do? They set standards for educational programs in music therapy. That's their primary goal, their primary purpose, so that schools that want to have an approved program have to create curricula that address those needs. A little bit of what we call inside baseball might be too technical for you, but just
that's fine.
The initial difference when there were two associations, the initial association said, well, if you want to have an approved program, you have to offer these courses, 25 courses. The new association said, well, we don't really want to dictate what courses people offer. That was curriculum based. The new association said, we want a competency-based education. Basically, we just want to articulate all the skills that a competent music therapist should have. Now, a school can design whatever courses they want, as long as those courses lead to the development of these competencies. So it was curriculum-based versus competency-based.
I have a small little question to interject. Great moment to tell me the skills of the nowadays music therapists. What are those?
Oh, I mean, there's probably a couple of hundred content areas.
I know, but we're talking about the educational.
What I'm saying is, if you look at their list of competencies, they're in three major areas.
Okay.
Musical foundation, so it'll articulate a whole set of musical skills. Theoretical foundations, which will articulate a whole set of skills and knowledge about human development, human growth, human functioning. And then there are music therapy skills and competencies related to the music therapy specific theories, practices, assessment, goal planning, evaluation, ethics, all of those things.
Thank you for clarifying that.
Everything a therapist does, there has to be coursework dedicated to that skill.
Mm-hmm.
So the two organizations in 98 unified, and now schools can do either of the two. They can either say, we want to get our curriculum, or we have curriculum, and we'll demonstrate that this curriculum will lead to the development of the competencies.
What does NYU do?
We were the home of the rebellious organization in 1970. We've always believed very strongly in the competency-based education because it's the country. I mean, you know how big the U.S. is, and it's so many states and different laws and individual variation. So we never really wanted to dictate in an authoritarian way. We wanted to give license to the schools to creatively offer the courses that really suited their resources. And maybe they were in a school of music, maybe they were in a college of arts and sciences, whatever. One of the unique things about NYU is there's 60 or 70 university programs. We're one of only 3 programs where people can start the study of music therapy at the master's level. Almost all the others, people start at the undergraduate level. But in as early as the mid-70s, we closed our undergraduate program because we felt that really to be a therapist in the way we think of therapy requires someone with more life experience and maturity that is endowed at the graduate level. So we only have master's and doctoral programs now. Mm-hmm. There's 2 other schools like that, but it's kind of been an intra-professional battle that, we feel it's people can major in music therapy, but really the entry professional level should be someone with a graduate degree because you need that level of sophistication and maturity to be really effective as a therapist.
Yeah. So are you maybe familiar with the European Music Therapy Association? Did you do any projects with them? Do you have any connections there?
Yeah.
Are they doing anything different than US does? You probably know about it.
Yeah, I mean, somewhat. So I would say in the 80s, 90s, early 2000s, I had a lot more collaboration with my European colleagues. I lived in Denmark for a year. My wife was a music therapist from Denmark. So I was very involved in a lot of international efforts in Europe, South America, in Asia as well. And so the US was the first country to actually professionalize the practice of music therapy with an association and university study, but it was soon followed in Europe. I mean, the main music therapy centers in Europe, I would say, are the UK, which has had a number of practices, Scandinavia, not so much, but Norway and Denmark. Germany has had a number of music therapy programs. And for some reason, the UK and Northern Europe has been a little more active than Southern and Eastern Europe.
Eastern Europe.
Italy, music therapy seems less advanced in some of Greece. It's there. It's in all these countries, but it seems less mature in a certain way, not in a bad way, just it's been around. One thing I think, there was a European model of and I think it goes back hundreds of years, to even psychology, where each university would have its own approach, and there would be,
the school approach, yes, different schools.
And so then if you looked a lot like a country like Italy at one point had 5 or 6 different associations. Every school wanted its own association with its own president, and we do it this way. And I think in the US, we overcame that division. There were 2. And the UK, I think it was overcome, and Scandinavia. But in other countries, I think it's been harder to overcome and to bring unity to it. So, but I will say, boy, there's music therapy just about most countries around the world, some form or another. And every 3 years, there's a World Congress of Music Therapy. There's one in July in Vancouver, which I'm going to and presenting at. But it's amazing just to meet music therapists from 100 different countries all over the world.
What are you going to be presenting in Vancouver?
In Vancouver, I did a research project where I interviewed autistic adults. Obviously, these were verbal people, not about music therapy, them about their everyday use of music. How did they use music in their lives? What role did it play? With the idea being that music therapists have been working with autistic people for 70 years now, but we don't really know how autistic people experience music on a sensory level, aesthetic level. Is there an autistic way of experiencing, or is it the same as non-autistic people? And so the idea was, if we're claiming that we're going to help autistic people use music as a health resource, who is the expert here? It's autistic people. And so I decided, there was a woman, Tia Denora, a sociologist of music, who had a well-known book in the area called Music in Everyday Life. And she interviewed people about how they use music in everyday life. And I said, you know what, I'm going to do that, but for autistic people. And so I did really in-depth interviews with 30 different people, just about the role music played in their life and how they used it as a health resource, how they used it to address some of the symptoms of autism, and how they experience it on a sensory level, on an aesthetic level. And I'm going to present some of the initial findings from that research. And the idea of providing basic research for music therapists to then use. So
to have an access to it later. Yeah, wonderful. So you are the author of many books on music therapy. One of them is The Study of Music Therapy, Current Issues and Concepts. What would be the hottest issue in music therapy to nowadays?
Well, I think the book had 13 or 14 chapters. And I think a lot of the issues were things we talked on. What's the music therapist's identity? Is it a health professional? Is it a musician who uses music, or is it a musician who does therapy, or a therapist who uses music? What is the role of verbalization? Is it always important? What is community music therapy, and is it even therapy? Should therapists be composing music with their clients, or is that unethical? Should they perform in public with their clients, or is that unethical? What's the nature of the therapy relationship in music therapy? You know, there are very strict ethical guidelines for therapists and clients in the world of psychotherapy. But as music therapists, we're showing a level of our humanity. It's unavoidable. We're playing music with people. We're meeting musician to musician, and we're evoking feelings and thoughts and desires in people to bring their music out into the world. And do we have an obligation to help people move their music out into the world? So all of these issues were the current issues and concepts: verbalization, relationship, community work, yes or no, performing, composing. All of these different areas are things that music therapists disagree about. And also, what is music therapy? Some people say, oh, well, you know, human beings have been using music for thousands of years as therapy. You know, you look at indigenous cultures, non-technological societies, shamans are the first music therapists. So I look at that and I said, well, is that really true? Is what we're doing just an extension of what shamans did through ritual use of music? Or is what we're doing somehow might have its origins there, but is somehow fundamentally different? So all these kinds of issues are things I take up in the book.
You're also a performer. Can you tell us a bit about that?
Are you sure you want to know?
Yes.
I play rock and roll piano. And I'll say, if it wasn't for NYU, I went to the school in 80, and I did not have a formal musical classical background. If it wasn't for NYU that allowed me to enter. Without that background, I never would have become a music therapist. But I play piano in a Grateful Dead tribute band, and perform 2 or 3 times a month doing that music all over the New York City metropolitan area, New York, Connecticut, New Jersey. Very interesting. My experiences with that band are the reason I am a music therapist. In my engagement with that music, going back to the 1970s, I saw how people use their relationship to that music as a healing force, and that it gave them a sense of meaning and purpose in life, a way of relating to others. People would talk about being healed at the concerts. And I would say that the Grateful Dead approach to music, which was very spontaneous, improvisational, and experimental, informed my music therapy approach, which has those qualities. And the last thing I'll say is a lot of music therapists sort of leave their non-clinical musical identity behind when they become musicians. And I think that that's wrong. I think everyone who's a music therapist is a music therapist because of experiences they had in music without music therapy. And so I encourage my students to sustain their non-clinical music identity throughout their career as music therapists. And if they were performers, don't give that up, because that sustains and feeds your own musicianship. And there's some of the things that we experienced. So, for example, a lot of music therapy clients don't have a concept of therapy. For them, it's just music time. I wrote another book called Band, where I talk about how for the client, it was just like, like when I was 15, the garage band with my friends. This client I know looked at his time in therapy as that way. And I realized that sometimes what we do as music therapists is provide the same music experiences that we got for people who don't have the capacity to create it for themselves. So I can talk in real clinical terms about this one client in the book, Playing in the Band, but I can also say it gave this person an opportunity to engage with peers around music and perform this idea of identity creation, that our relationships with music are an integral part of our sense of selves and our identities for many people. And so there are many people who don't have the intellectual, cognitive, or even economic, sociocultural resources to do that. And sometimes in music therapy, we're just providing the same experience that to music. Yeah.
Last but not least question. So you also were teaching at a Temple University, and you got the Lindbeck Award for distinguished teaching over there. So what is that? So you have so many students in front of you right now. What is that one thing that you think is most important for your students to learn?
That's okay. The single most important thing, again, I've written about this in another book called Music-Centered Music Therapy. And that is this: the official definition of music therapy by the American Music Therapy Association is the use of music to achieve non-musical goals. So whether the goal is physical, emotional, psychological, you have to articulate what the non-musical goal is to call it music therapy. Otherwise, you're doing just music. And what I want my students to realize is that that's not true. It's too limiting. That sometimes for certain clients, our most important goal is giving them an experience of themselves and the world and other people in music. The example I use with them is physical functioning. So for example, I'm a big hiker. I like to go hiking out in the mountains. Now, people might say, why do you do it? And say, oh, well, my muscles, it's great for my legs, and flexibility, it's great for my respiratory and lungs, it's great for my heart rate and cardio. You know, I'm doing all this. But if that was it, I would sit in my basement and just do, get on my elliptical. Hiking in the mountains is not for some non-hiking benefit. It's for what I experienced during the hike. So here's what I would say to them about their music. It's the same thing for many clients. They're not doing it for the non-musical benefit. They're doing it because of the way they feel about themselves and the world and about music while the music is happening. And I can say, we can look at these things. We could say, oh, Johnny developed more impulse control, or Sally developed self-esteem, as a consequence of being in music. But that's a secondary benefit. It's not the primary. Just like when I go hiking, I can say, yeah, it does all these things, but that's not why I do it. I think the same thing is true for a lot of clients. Those other good things are happening, but that's not the primary benefit. The primary benefit is what happens in the music. So I'm trying to give them a way of thinking that contradicts the official definition, because I think that's what the clients are feeling. And it used to, I would meet colleagues who would say, the clients think they're just doing music. They don't realize they're really doing therapy, And I tell the students, I said, you know what? The client's thinking, the therapist thinks I'm doing therapy here, but I'm just here because I love the music. And so what I want to say is the client's perspective is at least, if not more important than anyone else's perspective. I created this approach called music-centered music therapy because I wanted to honor clients' perspective on the process and create a framework in which their view of what was happening could be taken seriously and not dismissed. And what I felt it was condescending, what I heard from my colleagues who said that kind of thing. I understand why, because they want to legitimize music therapy in the outside world. They want to say, oh, look, it helps in speech and it helps in self-esteem and it helps on cardio, physical functioning. But my argument to that is, well, then we have to say we do speech therapy better than the speech therapist, and we do physical therapy better than the physical therapist, and we do psychotherapy better than the psychotherapist. We're kind of making the music a mere tool, a means to something else. My view is let's look at the music not as a tool, but as a medium of experience that provides an essential human experience. I mean, I really believe that a relationship to music is a nearly universal emotional human need. And for us to feel full and whole as human beings requires a relationship to music. I mean, and I tell people, I said, think about your own life without music. Think about what life would be. Nothing on the radio, no concerts, no playing music. You watch a movie, no music accompanying rituals or religious ceremonies, nothing. When you really think about life without music, it feels less human to me. And so I try to emphasize to people as music therapists, we're helping people incorporate music into their life, which gives them a sense of meaning and purpose and identity.
Thank you so much, Dr. Aigen. I have so many questions more, but I know you have a life too outside of this. And thank you so much for opening the whole beautiful world, the door of that to us today, the music therapy world. And we wish you all best in Vancouver in your presentation. And your students are so lucky. And thanks for clarifying a lot of music therapy issues with us today. Thank you so much.
Well, thanks for your questions. You know, speaking with an inquisitive and sensitive person such as yourself, it always helps me because it forces me to reflect. And where do I think now about this topic? And, you know, I feel like each time I do it, I make new realizations. So I appreciate that.
Thank you.